Welcome to the first session of the new to DM track on the second day of our 2020 MDF conference. My name is Loraine Dressler. I am the Southern California Support Group Facilitator, and I have DM1. I was diagnosed at the same time as my daughter and her unborn baby. But today, it is my great pleasure to introduce you to Dr. Jacinda Sampson, who will be interviewed by Dr. Lois Oppenheim. Questions to this interview were submitted by conference registrants, as well as calls to the MDF warm line on a regular basis. Dr. Sampson is a clinical associate professor at Stanford University Hospitals and Clinics. She is a neuromuscular and neurogenetic specialist who has been caring for patients and families with myotonic dystrophies and other familial neurological disorders for over 12 years. She is actively involved in observational and clinical research in myotonic dystrophy and other neuromuscular and neurogenic disorders. Dr. Oppenheim, Dr. Lois Oppenheim, whose husband has DM2, is University Distinguished Scholar, Professor of French, and Chair of the Department of Modern Languages and Literatures at Montclair State University, where she teaches courses in both literature and medical humanities. She is also a Scholar Associate member of the New York Psychoanalytic Society and Institute, and honorary member of the William Allinson White Society. Dr. Oppenheim has published more than 90 papers and authored or edited 15 books. She has been a visiting scholar at NYS Psychiatric Institute and is co-creator of 2 documentary films, one on mental health stigma and the other on psychosis. Dr. Oppenheim, please take it away.
Welcome to day 2 of this conference. Before we begin, I'd just like to thank Dr. Jacinda Sampson for addressing with me today the many, many questions that we were sent in by those registering for the conference and others that have come up over the years in a variety of support groups and elsewhere. Since my husband was diagnosed 5 years ago and I became very aware of myotonic dystrophy, I've become very aware of other people's questions as well as my own. And it's really an honor to be able to converse with her. So I just wish to thank her. I'd also like to explain that the questions that I will put to Dr. Sampson fall into a number of different categories. We certainly won't be able to get through all of them, but we'll do our best. For those that we are not able to really cover, additional information relevant to these categories can be found on the website. For example, we'll start with the signs and symptoms of myotonic dystrophy, and Dr. Lori Gutman gave a presentation yesterday on DM symptoms. There was also the DM 101 session with Dr. Erica Green yesterday as well, and a session on the gastrointestinal issues and another on nutrition are also part of this conference, and they'll all be posted to the MDF Digital Academy in the next few days. I would also add that the speech and language pathology guide is on the website, as well as the nutrition guide and the anesthesia guidelines. And finally, there's a clinic visit planner on the website that will help you to organize your symptoms and any questions you may have for your clinical care team. So please do go to the website for anything we may not have a chance to cover in this hour. So, having said all that, the first question I would put to you, Dr. Sampson, is there a possibility of reversing or delaying myotonic dystrophy symptoms and not showing symptoms anymore? Is the research, in other words, focused entirely on inhibiting progression of the illness, or is it also, is there room in that research for something else?
I think this is, a really good question, and one of the areas I hope that there is hope in this disorder is that, while there is a progressive component to this disease, and there are some changes in the muscle that occur over time with scarring called fibrosis or fatty replacement and decrease in muscle bulk, that there is the opportunity for improvement, that we think that based on animal models and some of the studies done in mice, that there can be some prospect of improvement. So that if we can change the underlying splicing problem in myotonic dystrophy, that will give an opportunity for repair, not only in the muscle, but in other tissues. It's going to take some time to find this. And I think as far as designing clinical trials, the first and most direct way of finding an approved therapy will be in slowing progression. But our hope mechanistically is that we will be finding treatments that can lead to improvements. Mm-hmm. Now, there might be parts of the disease that aren't going to have reversibility, but we're hopeful that there are areas that do. And I think it's going to take more study and time to know about this. But there are some studies, for instance, by the Optimistic group, looking at exercise and seeing some improvements in muscle function and bulk with activity that gives us hope that there's some changes possible.
Good to hear. In general, muscle pain, such as of the back, the shoulder, et cetera, is a common occurrence with DM. And one of our registrants asked, why does that occur? Insofar as myotonia is an inability to relax muscles, it would seem that generalized pain not associated with myotonia may not necessarily be related to DM, and yet many patients complain of such pain. Do you have a way of explaining that sort of discomfort?
It's a good question. I know from Chad Heatwool's work is that pain can be a prominent symptom in both type 1 and type 2 myotonic dystrophy. There seem to be some overlaps in characteristics with fibromyalgia, and it's often mistaken for fibromyalgia when people first present with symptoms. There is a little bit of literature by Drs. Fuller and Musharrab on myotonic type 2 that shows that there's a different molecular signature in the RNA in patients who have the pain, prominent pain, compared to those who don't in myotonic dystrophy type 2, but I don't think that that's well understood yet. I think that there is probably both peripheral pain sensation or pain threshold aspects that are part of the pain phenomenon in the myotonic dystrophy, as well as centrally in our central nervous system about how we perceive pain may also be an element. But this is certainly an area that needs more research.
You're actually reminding me of something else, which is studies that are done. There are many more studies on DM1 than on 2, or so it seems to me. How are people with DM2 to think about DM1 studies? They are separate conditions, separate disorders, and yet there's certainly a significant amount of overlap. So when somebody reads a study or hears a lecture on DM1 and they are sitting there with DM2, how are they to think about that?
That's a good question. There's a lot of overlap and commonality, and yet they are distinct disorders. I think, there's more and more focus on DM2 as its own, to describe it as itself. But some of the things that we do know are in common are its multi-systemic involvement, that it's not just a muscle disease, that it's a disease of many other organ systems, including heart and eye, and endocrine system and brain. And we know that both of them involve abnormal splicing of a large array of genes, some of which overlap between the two disorders, but some of which are distinct, and there can be some differences between them. So they have a lot in common. So of them as being close cousins or siblings of disorders, that you can learn a lot from the studying each of the disorders together. But also we need to treat them as their own individuals within the same family.
Good, thank you. I'm going to actually quote here from one of the questions so that the person who asked it, I don't want to distort anything because it's a very precise question. How exactly do the muscles decline? Quote unquote, I have heard that it is similar to a band around the muscle, but I don't understand how. Also, will having more muscle help slow the breakdown? I think that's too important a question for me to try and reword it.
Sure. So I think when they describe a band around the muscle, what they mean is something that we see under the microscope in muscle biopsies called Ringbinden, which is German for a ring around the muscle fiber. And what that is that some of the skeletal elements of the muscle cell, the architecture that holds it together, gets reorganized in kind of this swirling circle around the membrane of the muscle. It's not unique to the myotonic dystrophies, but it's a pretty characteristic finding. But I think the thing that we do see more commonly are the more typical. So it's not a band around the whole muscle as in a constriction or restriction of the muscle. It's something that we see under the microscope for that band phenomenon. What we do see under the microscope is that the muscles are trying to repair themselves, and that there is over time some loss of muscle mass and changes that we call are dystrophic changes. Dystrophic changes mean that the muscle fibers are getting replaced by a type of scar tissue, connective tissue, or called fibrosis, and fatty replacement, which means that some of the muscle fibers have fat cells kind of move into the muscle itself and take up that space. It doesn't mean fat as in overweight or eating too much fat. This is something that occurs when a muscle is trying to regenerate and repair, and there's some lasting changes. So those are the things that we see under the microscope, and how the changes in splicing lead to that are something that we are still learning about.
Well, now that you've mentioned the word fat and overweight, a number of people with myotonic dystrophy face the issue of losing weight, considerable amount of weight, because they're losing muscle mass. Is there a way of stopping that weight loss? Do you have recommendations for people who actually do get too thin as the muscles wear down?
It's a hard thing to reverse and to fight. I think, we talked a little bit about activity and having an exercise plan that's designed by your physical therapist so it fits your body and it's individualized, but also talking with your speech therapist and your nutritionist, because sometimes not deliberately, and it's, unconscious, if swallowing is difficult or food preparation is difficult because of the involvement of your hands and swallowing, sometimes it's easier to choose foods that may not have as much nutrition in them or to have imbalances in your nutrition. So having someone just look at a nutrition diary and make sure that everything is balanced can be very helpful, because we want to make sure your body has all the building blocks that it needs. Now, taking supplements or having excess protein isn't necessarily a benefit. If your body has all the building blocks, taking in more doesn't necessarily build more. We just want to make sure that it's balanced and level. The other thing that might be a factor is that diabetes, even if you're skinny, can be common in myotonic dystrophy, and that affects your body in a number of ways. So making sure that you aren't developing diabetes can be important, even if you don't have excessive weight gain, because that would change how, what your food choices would be and your management.
Right, of course. Thank you. So one other issue that is often associated with DM1 and DM2 is fatigue. And I'm wondering if an individual has heart involvement, as they often do. Certainly, I'm more familiar with DM2, but and they are unable, because of that heart involvement, to take any of the medications that are sometimes given to help with fatigue and energy levels. Is there anything else that these people might do?
That's a good question. I think, if you have cardiac involvement, the first thing is always to get the okay from your cardiologist about what adjustments you make. And certainly some of the stimulants aren't advised if you have heart involvement. But there are other things, if it's okay with your cardiologist, to optimize all the other things that you can. And sleep is one of them, that if you aren't sleeping well, or if you have nighttime decreased breathing drive or sleep apnea as part of your myotonic dystrophy, that treating that with non-invasive ventilation, such as BiPAP or CPAP, if it's mild, can be very, very helpful. It isn't going to make the fatigue go away 100%, but it might help to a degree. And then all of those other elements that can be addressed, whether it's maximizing your activity so that you've got good resilience and endurance as much as possible, making sure your nutrition is good. Are there any underlying endocrine problems such as diabetes or a low thyroid problem that could be contributing are important. And maintaining a routine schedule. I think patterns are important in our life, including wake and sleep and activities to help us get moving when our bodies don't feel like it. Right. And that can help because if you are less active because of inactivity or apathy or decreased energy or fatigue, then that starts to take away some of your reserve energy in your daily activities.
Thank you. So one question that seems to come up very often, understandably, is how quickly the disease progresses, and that is linked to the question, what is the life expectancy of those with myotonic dystrophy?
That second question about life expectancy is the one thing that we hope to have an impact in with better preventative care. So the two things that could shorten one's life expectancy with myotonic dystrophy, both type 1 and type 2, are heart issues. And so seeing your cardiologist and monitoring your heart rhythm and your heart function are really important. And then the second is pulmonary problems such as pneumonia or aspiration pneumonia, where swallowing leads to food or water getting in your lungs and setting up an infection. Those are the two most important things and that can affect your life expectancy. And there are elements to that if we're aware of it, we can try to prevent it to a degree. And so I think that's important. Much of the literature on life expectancy is a little bit outdated sometimes and doesn't show the benefits of preventive care. So we're hoping to shift that over time with our efforts. But those are the two things. We do hear from a lot of people, and again, this is something that needs more study, that stresses to your body, not purely emotional stress, but physical stresses like a surgery or a trauma or an accident, hospitalization, being immobilized for some reason, leads to a decline in function. And so avoiding those as much as possible is really important. So preventing falls and injuries, getting your flu shot, all of these things are little things, but they're very, very important things in preventing those hospitalizations or illnesses that could really lead to a decline. And now in the time of COVID, we really want to avoid contracting COVID. So being careful, you and your family, as much as is possible to avoid contracting COVID, I think is a good strategy.
Yes. So we touched very, very briefly on the issue of the digestive tract, dietary recommendations, etc. There is one participant at least who would like to know whether there's urinary and bowel incontinence that is related to this disease. Is this something to be expected?
So as far as expected, as in everyone having the symptoms, no, not necessarily, because as you know, there's so much variability and variety in how myotonic dystrophy affects different individuals. But we do see it as a symptom that can happen to some people who have myotonic dystrophy, particularly if it's affecting your gastrointestinal tract prominently. And also in children, as part of their developmental delay, they might be delayed in learning toilet training and bowel and bladder control. But we do know that the muscles that control not only the gastrointestinal tract are involved, but also the sphincters, the valves that help control that, can be affected. And so, yes, it can be a symptom. And it's certainly something you should talk with your gastroenterologist about, because you always want to make sure that there's not some other explanation for a symptom that could be modifiable. And even if it is attributable to myotonic dystrophy, there may be patterns of, scheduling when you do your toileting, or dietary changes, either having more fiber or more water, because the GI involvement can go either way. It could be diarrhea, or it could be constipation, or it could be both, or it could be stomach pain or cramps. That it really helps to have those plans individualized with your nutritionist, your gastroenterologist, your physician.
So if there's a parent who has DM2 and a small child who has been trained, but then starts soiling, has encopresis, soiling the underwear with stool, is that likely a sign that this child has inherited the illness?
Possibly. I think it's an individual, that's something where you need to get an opinion of a specialist and to get some testing done to make sure that there's not some other underlying issue. So it's hard to say for an individual basis, but I would always, if there's a symptom like that, get it checked out by your physician and a specialist, and not just attribute something as being unsolvable related to the disease without looking into it some.
Good. Okay, so here's a question for you that's kind of doesn't fit into any of the categories, but and at the same time, it belongs here, I think, at this point in the conversation. How might both men and women be affected sexually if they have myotonic dystrophy?
That's a good question. So there's a lot of different elements that can play into both reproductive and sexual function in myotonic dystrophy. And I think this would be a really great topic for one of our future MDF meetings, because some of them are specific to men and women. One of the things that isn't uncommon in women is to have irregular periods, and also to have some increased risks of complications during pregnancy. So they definitely need to be followed by a maternal fetal medicine specialist when they're pregnant. While fertility is known to be decreased, it's not to a degree where you can rely on that as a birth control method, that it's still possible to get pregnant, often with unprotected sex. And that varies much between individuals. In men, there can be a lower sperm count, which can lead to decreased fertility. And there can also be a lower testosterone level, which is one of the endocrine involvements that can lead to, again, fatigue, decreased muscle bulk, as well as affecting sex drive and fertility. And that's something that you should see a specialist about, because too much testosterone can also be not good for your body, as well as too little. So taking off-label or over the internet testosterone boosting supplements could have potential harm to your liver, to your heart, and shouldn't be done without supervision. That being said, supervised testosterone treatment, if your levels are low, can make a significant difference in how you feel if you're a guy with low testosterone due to your myotonic dystrophy.
I wouldn't be surprised if the person who actually posed that question was also curious to know about erectile dysfunction.
That can also be an element in myotonic dystrophy type 1 and type 2. Mm-hmm. And some of the medications that are used to treat that, such as Cialis and Viagra, or the trade names, can be used, but you need to be cleared by your cardiologist first, because both of those can have cardiac side effects. So that could be a potential therapy, but you do need to talk with your cardiologist about that.
Okay, so here is another question that I'm going to quote directly. Regarding use of splints, my daughter finds them very uncomfortable at times, and they rub and produce sores and blisters or other skin lesions, further reducing their use. Is it okay for her to have some time out of the splints? In other words, when she's playing tennis, as she does with some support.
So braces are always something that people have pros and cons feelings about those, and having bad feelings about it often is related to a poor fit. And so if she's having sores or bruises or blisters from her braces, they need to be taken back to the orthotist to be modified. She might be outgrowing them. They might not be fitting right. She might need a different style. But some of the pros is that if you get good fitting braces, that it can help with your balance and it can help with your fatigue with exertion. And so there can be some real benefits to it. So it's all about fit and use. But yes, it's okay to be out of your braces for a while. And I know in summer and hot weather, it's kind of nice to let your feet breathe. But if you need them to keep from tripping and falling and catching your toes, then, it's important to put them on when you're up and about. So.
Okay, so before we move on into another category, there's one more question here that I'd like to ask you, which is related to anesthesia. Should somebody with myotonic dystrophy always stay overnight in the hospital for monitoring after some kind of surgical procedure, even if it was outpatient surgery?
That is a really good question. And, I know we always say a lot of it depends, but for certain procedures, for example, having your cataracts removed under local anesthesia is generally fairly safe to go home the same day. But if there's something that's given to you to make you sleep or relax during the surgery, that might be something you need to be observed for longer. But it depends on what the medication is, what the procedure is, who your doctor is, and what their familiarity is, as well as the anesthesiologist. And I know in many places, including our own, it takes special effort to connect with the anesthesiologist you'd be working with, because often they work on a rotating schedule. Pardon my hiccups. The other thing is it also depends on you. What are your symptoms of myotonic dystrophy? How severe are they? Does it involve your speech, your swallowing, your breathing? If they do, then yeah, that would be a greater concern, that you may not clear that anesthetic quickly. If you can be the first case of the morning, be watched for 6 hours, have a room ready for you, if you aren't quite back to your normal self before you go home, then yes, maybe you could go home the same day. But it's generally good to have a plan to be observed tonight if you aren't, if that same day. And certainly there are definitely certain procedures where we would want you to be observed overnight, because if you need medication for pain management, that pain medication might make you feel loopy. It might suppress your breathing. It might slow down your gastrointestinal tract. And you don't want to discover that at home on your couch at 2 a.m. We'd rather know that when you're in the hospital. And it's better to be watched overnight and have nothing happen than to go home and to have something where you don't know what to do. And so you should always talk with your myotonic specialist. And if they can connect with your surgeon, your anesthesiologist, that's the best way to have a plan that works for you.
Very wise counsel. So I'd like to move on now just for a few moments to some of the cognitive and psychological symptoms that people are interested in understanding better. I believe it's becoming increasingly apparent now that certain neurodegenerative diseases have a neurodevelopmental component as well. So the questions having to do with cognitive and psychological components of the illness come up quite often. Could you tell us anything about whether there are certain psychiatric disorders that are associated with this illness, whether there are certain personality features, schizotypy, for example, social isolation, depression, which is often attributed to the response to the diagnosis, but other people have spoken of its being part of the illness itself, neurobiologically speaking. Do you feel that the personality disorders, changes in personality, all of that? So there's about 20 questions there in
Wow.
one.
I think this should be its own conference at some point. And it certainly is something that is being discussed increasingly in all of our clinics and research groups. And there's some really fantastic research going on in this field. I think Lori Gutman has and Pagnopoulos have done some work on this. If you look at the Optimistic trial, they've just recently published some EEG data. I know there's work in England, Italy, elsewhere looking at MRI imaging. It's something our group at Stanford has a particular interest in as well. And we are finding differences in functional MRI imaging and the brain white matter tracts in imaging that we think underlies some of the cognitive and probably personality changes that can be seen in some but not everybody with myotonic dystrophy. And so some of the changes that we most often hear about in clinic are things related to what we call executive function. Mm-hmm. Executive function is it's the putting everything all together in your brain. It's now none of us, multitasking is kind of a myth that people think that we're good at it. All of us monotask to a different degree. And it's what we call task switching in a way. It's the ability to switch from one task to another. And that can be difficult in myotonic dystrophy. There's also some disinhibition that can be seen. And one of the things that many people report about their family members, but sometimes you might not see it in yourself, is apathy. And how do you tell apathy from the fatigue and the sleep problems and the muscle weakness of myotonic dystrophy? It can be really hard to tell from all these different factors, but apathy is not it's not a moral judgment. It's not your fault. It's part of how your brain works. And what it means is that ability to start a new thing or initiate activity. And sometimes cognitive behavioral therapy can help with that, or some other aspects. So that's something that's commonly noted. And apathy can also be a symptom of depression. Mm-hmm. Now, is the depression a reaction to your diagnosis and the limitations it's putting on your life and your activities, or is it part of the chemical makeup of your brain? Well, it's probably both, which means that you need to address both aspects of it in order to treat it and manage it. So I always recommend seeing a psychologist as not just medical management, but also having counseling, because there's so much about working with your family, working in your environment to adapt to these brain changes, but also seeing a neuropsychiatrist, which is can take a few hours, but it's really quite interesting. Now, testing is hard. The whole purpose is to kind of push you to your limits. So if it's difficult, don't get upset. It's supposed to be. But what it will do is it will not only highlight your the areas that you have problems with, it'll also help you find your strengths. Mm-hmm. And then working with your neuropsychiatrist and working with your psychologist, are there strategies or patterns that you can develop and work with your family to overcome or adapt, or find out the things that you are good at in order to use those in your day-to-day life. So I would suggest, this really takes a team, and it can be difficult if your insurance doesn't cover some of these services. And so I think this is why advocating for mental health and psychiatric health is really important.
You mentioned switching, which is often associated with attention deficit disorder. Is ADD or ADHD, is that something that you see commonly associated with myotonic dystrophy?
It is. And one of the questions that we're still trying to understand is this an element of the kind of structural or biochemical changes we're seeing on brain imaging, or could this possibly be secondary to some treatable aspects of the disorder, such as sleep, depression, and asking people to task switch where there may not be that flexibility, or that might be an area that's difficult, is something that we need to do more research in. Certainly, if, assuming your cardiologist says it's okay, that's going to be my repeated theme. Always check it out with your cardiologist. That some people do notice benefits from the neurostimulants that are used in ADD, ADHD. Now, how much of that is that for it itself, or how much of that is also helping with the fatigue aspects, is unclear. But for some people, they find that that is a helpful therapy, but does need to take coordinated care for that.
Okay. Are memory disturbances often associated with DM?
They can be, and there is also some evidence that over time there can be some progressive nature to memory disturbance in myotonic dystrophies. That being said, the good news is that when you look at brain changes on autopsies of people who've given their bodies and brains to science, is that we don't see the same type of changes that we see in, for example, Alzheimer's disease. It may be more a connectivity problem, but we do know that there are some proteins that overlap between the dementias and myotonic dystrophy, and that tau is abnormally spliced in myotonic dystrophy. But we think that it may be a little different than what's seen in Alzheimer's disease. And this is something that we need to learn more about. But memory problems can be a feature. But also some of the elements that we talked about already. Poor sleep can impair your memory function. If you have cardiac problems like untreated atrial fibrillation and you're having little strokes from blood clots going to your brain, that can affect cumulatively your cognitive function, even if you don't notice any clear stroke-like symptoms. So taking care of your heart and your heart rhythm, very important. All of those things are elements.
So you mentioned cognitive difficulties. Are learning disabilities in children often, in my own readings, I see it most commonly with congenital myotonic dystrophy. I'm wondering about all forms of myotonic dystrophy.
Sure, and it's such a spectrum. It really is. And I think we have, it was early on recognized that in congenital myotonic dystrophy that intellectual disability can be a feature. And in juvenile childhood onset, there can be other learning disabilities. So I really encourage to get an IEP plan, an individualized educational plan, because I think maximizing and optimizing your education early on is really, really important for these kids, for their lifelong function and independence and abilities. It's always difficult when you have multi-systemic involvement to pay attention to every single element all the time. But I think having the school involved for an IEP is really important. Is there some component of developmental changes in brain structure? Yes, we think that could be part of what we're seeing on imaging, but I think there are some clinical trials that are in the works and hopefully soon to be enrolling, such as the AMO study, that might that are looking at that as one of the outcome measures as to whether there's a change.
You referred to childhood onset. I think that something that's still quite vague for many of us out there is the notion of early onset versus, well, let me see how to best explain this. If a child has symptoms or an adolescent has symptoms, but they're not diagnosed until the age of 35 or 40, what do you call that? Do you consider it adult onset because they were not diagnosed until much later?
No, we use the time when the symptoms started, not when they were diagnosed, as the way to define when the symptoms happened, because so many people have a delay of diagnosis, 7 years on average for type 1 and much longer for type 2, that we use the onset of the symptoms. And it's not unusual for an adult to say, you know, looking back, I had a lot of trouble with, for example, ankle strength or a particular aspect of my education with attention or a particular learning disability in childhood that was unrecognized. And so that doesn't mean they didn't have myotonic dystrophy then, it just means that it wasn't recognized.
Thank you. That clarifies a lot. So I think we should move on to another category now, which is of interest to everybody, which has to do with current studies and treatment and so on. And just to let everybody know that the research sessions of the conference will be available on the Drug Development Pipeline and the MDF Digital Academy, and that the MDF Family Registry has information available there as well. Also, a recent webinar on DM gene editing is available on the Digital Academy, and the clinical trials site is always available for viewing, and all of this is extremely helpful to anybody who wishes more information on all of this. Do you have any updates for us on any stem cell research by any chance?
I'm afraid stem cell research, I don't really have any updates of clinical trials, but I would caution people to be very careful about off-label non-FDA approved therapies, because there are some risks. I've seen in other diseases people having adverse outcomes related to non-approved stem cell therapies, whether it's having an immune response against cells that aren't your own, or those cells can kind of set up a place and grow in an uncontrolled manner and cause a mass. But I think it's also just, it just hasn't been documented to be beneficial yet, and there are risks associated. So if you're going to try stem cells, only do it as part of a sponsored clinical trial where it's being supervised and there's follow-up, so that if there is an adverse event, someone is looking for it and following for it. Plus, sometimes these therapies off-label done by unapproved clinics can be really very, very expensive. And so consider the potential financial side effect of it as well.
Okay, so one of our participants has asked, are there any potential gene therapies that can deactivate the CTG sequence on the abnormal chromosome and activate the normal chromosome to be dominant?
I think that's a really interesting question. I think you're probably referring to CRISPR, which is the hot new gene therapy or gene editing technology. I think you just mentioned that there's a webinar about that, so I would refer back to that. Okay. I think probably the RNA-focused therapies are closer to clinical trials and in the pipeline, and so RNA is the working message of our bodies. So DNA is what's in the nucleus, is our reference library, but the RNA is kind of the working recipe for how do we make proteins. And targeting that is a lot more flexible and targetable. And I think that's what you're going to hear about in the research session with Andy Berkland, Nick Johnson, and Eric Wang.
Excellent. Okay. Is there a new definitive saliva test to confirm DM?
That's a good question. I don't That one I don't know. I know one of the difficulties that we have with saliva testing is making sure we get enough DNA of good quality, because it takes nice long strands of DNA to detect it, the repeat expansions. And our technologies are improving for saliva, but I still, in my clinic, I usually order a blood test.
Okay. I'd like to jump into the DM2, a lot of questions for a moment, because I think we are running very close to the end of the hour. There were many questions that were posed about DM2 specifically. Now, I know there is a DM2 research session today or yesterday, I have to look at the program, and that will be available to view on the Digital Academy after the conference. So we don't need to spend too much time on that, but there were a number of questions posed, so I'd like to just cover a couple of them. Is there a realistic time frame that you could cite with regard to a cure for DM2?
Oh dear. I wish I had a crystal ball, but I think things are accelerating in DM2 research as animal models are being developed. I don't know if Dr. Cooper is giving a talk, but also looking at antisense therapies designed for in vitro models. Mm-hmm. That I know that there's some work going on in that. So I think that there is certainly an uptick in acceleration in that. I think, identifying people with DM2 and getting them involved in registries is going to be hugely helpful in being able to have a community to reach out to participate in research once the therapeutic is identified, is going to be key, because as you all know, DM2 is not as easily recognized as DM1 and often takes a lot longer to diagnose. So if we can get everyone possible involved in registries, that will give us a bigger community to work with once the therapies are ready to go.
This question just jumped into my head, but I recently read something about DM3, that there's one family who has been identified as having DM3. Are you familiar with that?
I would talk with the basic scientists about that a bit more. We've always known that there are unusual families that have myotonic dystrophy, but we're not finding type 1 or type 2, and that there might be something else out there. So I have no doubt that there will be more genes to follow. I know that there's many more polynucleotide repeat disorders being identified now than there ever have been as the genomic sequencing tools improve, with long reads and with other analytical tools. But how common are we going to find these rarer myotonic dystrophies is unclear. And right now we don't have a clinical gene test for those, but hoping to hear more in the future. But I'm going to refer you back to the basic scientists like Charles Thornton and Tom Cooper. And
I'm going to throw one other thing your way before we close, and that is something that seems to get various answers from various people. So is the increase in repeats associated with a worsening of the illness?
That's a good question. So there's correlation and there's causation. Uh-huh. And there's, it's hard to tell what is what, because one difficulty is that in all the different tissues of your body, there's different repeat sizes. And even within one tissue, there's different repeat sizes. So the analogy that I use is if I draw a blood sample from someone with myotonic dystrophy today, and I run a sequencing gel or a Southern blot to look at the size of the repeats, there's going to be hills and valleys. There's going to be one that's kind of like the tallest mountain. And that's the one that we statistically typically pick and look at it and follow. But it's difficult to follow someone's repeat length over time, because if I drew different samples on different day, depending on, a lot of different factors, we might get slightly different numbers. And if I took blood versus liver versus muscle versus brain, those are all going to be different numbers too. So how
Sure.
do I pick a number? And one of the things Dr. Monkton has been working on is what he calls small pool PCR, in order to figure, is there a reliable, consistent way we can find a number that we can attribute to. And I think in myotonic type 2, that's particularly difficult because it's a very large gene. We think that having repeats where the repeat is a little different, that there's some variability. It's not a perfect, every time it's cookie cutter. There's some differences that also affects severity. So how do we incorporate this into our models is something we're learning about. But we do know that as you get older with myotonic dystrophy, the repeat sizes can get longer. But is that related to the disease getting worse, or how long you've had the disease, or the propensity of the repeat to expand? That is something intrinsic too. So I think it's a lot of these things together, and finding the chicken and the egg is going to be a challenge. And I think probably the basic scientists all have hypotheses about these, that I would listen to their presentations to learn more about what the current thinking is on that. But I think if we could stop / reverse / affect that, progressive lengthening of the repeat expansion would be a very interesting thing. And they are working on that in mouse models.
I would just like to say before we end that we really want to encourage everybody to sign up for as many clinical trials as possible. It is the way that we're going to have answers from you, right? And from your colleagues. And so do go to the DM registry and sign up, please, so that we can support all the efforts of Dr. Sampson and her team.
And I encourage, there's multiple registries. So there's the MDF registry. Rochester has a longstanding registry. We at Stanford have our own registry. Your local clinic may have their own registry. This is how we find people to ask them if they want to be in a clinical trial. So this is how we can get back to you about that.
That's great.
And then also, consider being part of a natural history study or an observational study, because that helps us get the information about how do we measure the severity of symptoms and all these different symptoms over time in order to design a good clinical trial so we can come up with proof for whether something works or not. So I encourage you to consider not only a treatment trial, but an observation trial. And studies can be as simple as filling out a questionnaire or giving a blood sample, or they might be more involved, like the natural history study. I saw one of the questions was, when is the NDM1 natural history study recommencing? It already is. So we are resuming our natural history study on that. Would love to see people call your closest site to be involved. And so that's my cheerleading about that. I think there's also a breakout session with some tables with different institutions about what they're doing with their research.
Well, thank you so much for your time. This has been so extraordinarily informative, and I know that I speak on behalf of everybody when I thank you for all you do, and it was lovely to see you.
Well, you're welcome, and I miss seeing people in person. I hope this substitutes, at least in some small way, for the chats we have in the hall and over coffee and over meals at the conference, and I really look forward to seeing people in person again.